Welcome back for another episode of Talking with the Experts. This is episode 8. So we've done a lot in between since our very first episode, and I'd like to welcome to the desk today, welcome back, Denise Stewart. Welcome, Denise.
I'm so excited to be here, Kate.
So we actually did our very first Talking with the Experts interview together almost 12 months to the day. So I can't believe how we've timed this so beautifully. And so for those who haven't seen the episode that we did 12 months ago, Denise Stewart has over 3 decades of experience as an occupational therapist specialising in breast cancer rehab and shoulder rehabilitation, and has developed numerous courses for practitioners in the cancer rehabilitation space, and also has her own clinic in Brisbane, Queensland, for her patients going through breast cancer treatment. And so what we talked about last time is the hidden scars of breast cancer. And that included surgical scar tissue for lumpectomies and sentinel node biopsies, radiation scar tissue, and the infinite time frame of the body's healing process for radiation scar tissue. And so we then went on briefly to talking about your assessment called Reach Out the Back assessment and Reach Out the Back stretch. And we did touch on that very briefly. So today, I want us to elaborate on that, because I've done quite a few of your courses, Denise, and I use those techniques of the assessment and treatments in my clinic every day. And I see how beneficial it is to my patients. Especially the Reach Out the Back stretch. And I also have my patients tell me, wow, my shoulder range just gets increases so much doing those stretches, or the relief of tightness in the axilla and through the chest relieves as soon as they do those stretches. So let's get in and talk about continuing on with that Reach Out the Back stretch. So Denise, how did you come about in developing that assessment and stretch?
Kate, first of all, I have to go. You make my heart sing when you say that you use the test all the time and that it's worthy, because that is, I think why I'm here. It's like this is to develop the things that women after breast cancer need to be able to get the treatment that they need and deserve. And what I found was that in the research and in our training, that it was always about arm to shoulder flexion or shoulder abduction. So all the research was always looking at an individual's flexion and abduction, and then the group average. And it was never the full range of movement when I would see my patients. And so then I started hitting on some great treatment techniques, and I was getting those full movements back again. But the person was still saying, there's still problems. There's still something. And I go, well, we've hit the flexion, we've hit the full abduction, and I actually can't see what they're talking about. And that was the problem, was me not seeing as a therapist. And if I can't see it, how can I develop a treatment to suit that? And so that's when I started thinking about it's got to be bigger. It's got to be a bigger stretch. And so that's how Reach Out the Back test started. Was through listening to the patient or look to the woman and being able to match up something that suited me to be out so that I could see it.
And certainly when you get someone in that side lying position, and in either the 10 o'clock position with their arm or the 2 o'clock position, how bleedingly obvious those restrictions are, and identifying cording in those positions, and just noticing the direction of the dissection bed following sentinel node biopsy or axillary dissection, and a lumpectomy especially. It's there, and identifying a seroma as well. So in someone lying on their back with their arm up, a seroma oftentimes hides. You get them into that side lying position, and there it is. It pops out.
And so that's right, Kate. So you've touched on a couple of things there. One is that I use the clock analogy. So we actually use 9 o'clock, 10 o'clock, 11 o'clock, and then I added in 12, but we can talk about why later. But at 10 and 11 o'clock, when people then reach out the back, it stretches the skin, and we've got a lot of skin there, for a very good reason. We need our arms to move. And it's about getting the skin stretch and the breast tissue, if they've got breast tissue, to stretch enough so that those impairments or those things come to the front, so they become more obvious. And so you don't have to go digging in, you don't have to go digging in deep, which is such a relief for everybody. So you can see them really clearly. And being the second part of the testing method is that one is the movement, and the second bit is palpation. And so that we can have our hand on the area, and straight away you can feel in those big reach out the back tests, you can feel the tension. And the amazing thing, Kate, is that research to this very day is still, the researchers, the people that are researching are saying, oh, but we need to know more about the impairment. And I go, can you just feel it? It's there.
It is. You can just even not touching, sometimes you can see it. It just draws out, and it's right there.
Yeah, and I guess if we can just talk to the person that might have breast cancer, you might all be shaking your heads on, oh, don't you know? And you know what? We weren't taught this in university. This is a whole new field of study, and so we didn't know. We didn't know these things existed, where they started from, and where they are. So please be patient with us, and that's why I'm teaching this technique or this testing method.
Absolutely, and it all made sense when I did that the face-to-face workshop with you last year. So I initially had done the online course, which was very valuable, but I think once you get face-to-face, hands-on, and identifying those techniques and practicing those techniques, then it makes sense 100%. And then I came back from that workshop and straight away started using the assessment, and I've used it in my clinic every day.
Yep. And Kate, it's really about that trusting and investigating with the hands and the eyes in reach out the back test. And as soon as, this is not rocket science once you got it, because it's just really observing what is there, but we need to place the body in a position to allow us to do that so easily.
So can you describe for our listeners and viewers what those positions are?
So if we use I use the analogy of the clock, and so if the head is 12 o'clock and the feet are 6 o'clock, then our arm is the arm of the clock. And so if I just use my right arm, then that is 9 o'clock, and then it goes 10 o'clock, 11 o'clock, and then 12 o'clock. And then if I was using my left arm, then it's 3 o'clock, 2 o'clock, 1 o'clock and then 12 o'clock. And what we do is we take up those first, the starting position, which is the o'clock position. And then from there, we're reaching out the back. And so it's a big stretch, and it's a big stretch of different parts of the pec muscle. And so, for example, at 9 o'clock or 3 o'clock, the amazing thing is it only stretches a portion of the pecs. We were told that doorway stretches were great for pecs, but in fact it's only for a portion of the pecs. And so each o'clock position that you go to, then it's a different angle of the pecs. And the other part of the test is that we can work out how far people can go back to that first point of discomfort. And the other part is working out, well, if there's a limited range of movement that we're observing, is that because of tight muscle or is that because of scar tissue? And so then what we use is a tension up and then relax, and then see if we can stretch out a little bit more, which is a common method used in gyms or yoga, where you either tension up for a count of 5, or in yoga it's a breath in and a breath out. And what that does is it speaks to the tight muscle. And if it is tight muscle that's stopping the range, then the relaxation of the muscle means that you can go a little bit further. If it was scar tissue or adhesions like the seroma or the cording or tightness in the skin, then we won't get any more range of movement. And so that's why the test helps us to work out, what the impairment is.
And so in that side lying position and the placement of the arm, I tell my patients that using the weight of their arm plus gravity enables them to increase that stretch as well, without putting too much restriction on the shoulder as well. And they can actually lay in bed in that position, and before they get out of bed in the morning, put their arm up and put it out the back, and just don't rush the stretch and let it hang there, and get a bit more stretch.
Yep.
I actually use my assistant Kath, and in the exercise studio, I use so I can show patients what they're actually doing. So to give them that, I take Kath into those positions, and so then the patient can see exactly what is happening. I don't do the demonstration myself. I've got really tight shoulders, and I need to be doing more of this stretch because but Kath's got excellent range of movement, and so the demonstration works really, really well, and to give the patient a visual on exactly what they're doing.
Kate, I want to take up a point on that, and I get a bit fussy about words when my new word comes, because I would use stretch as well, but in the end it's actually about relax. And
Yep.
so it's and I say that because when I was learning this method myself, I had a shoulder problem, and so I would, just like you, in bed, I would dutifully stretch. And what I didn't know was that I was actually micro tearing. And so I was a diligent micro tearer, and I would wonder why it wasn't improving. And so the method is we kind of go, it's a stretch, but it's more about how much movement we've got in those positions. It is a stretch of the tissues, but really how we get it is through relaxation, because all the work that we do at our desks, at the kitchen, at the wherever, is always forward, and so everything does get tight. Yep.
And so your description of how you were talking about tensioning up. I think your description of how they can do it individually by themselves is pretending their hand is up against a pane of glass, and they try and push against that pane of glass without actually going through the imaginary pane of glass. That is how I've continued to describe how to tension up for a patient to do that.
Yep. The pane of glass is great, and you know why I did that was it stops people from automatically moving forward. And there's a really good reason for that, is that we all want to know that we're improving. We all want to know it's working. Are we doing it right? And so if we keep the arm in a position and then tension up and then relax and then go back from there, we can measure that easy enough. Even if we, all of us did angles in school, so we kind of measure that angle. But let's just say if you tension up and you move your arm forward and then you go backwards, you go, oh gosh, did I make anything out of that? And so the pane of glass is a perfect way of just keeping the arm still so that we can then measure. So there's reasons why, and that's the reason why.
Okay, that makes sense. So with radiation scar tissue and the tightening of the pec minor, I know in that position with the reach out the back, individuals on their own they're able to get in and palpate the pec minor. Can you describe that?
Yeah, this is probably something I've been working on for the last 12 months, and is new thinking. So it's hard to get any information if you go Googling it, Googling it. But people are kind of around the world are working on pec minor, and how do you measure tightness in it? How do you measure shortness in it? And so I go, actually, that's why I need to really focus on the 12 o'clock position. In 12 o'clock position, there is a stretch on pec minor, and where it is underneath pec major. It's if you put your finger on the beginning of the collarbone and then the end of the collarbone, it's kind of halfway in between. And what you do is go slightly under the collarbone and then go through the skin, press through pec major, and then under that is pec minor, and you can tell it's there because it's vertical fibers, and there's nothing else in the body that is vertical fibers right there. So you've got horizontal fibers of pec major, and then below that you've got the horizontal bones of the rib. So if you feel vertical, you know you're on it. And that it's only this wide, so two fingers wide. I just go, 2 fingers wide, and it's probably about just longer than 2 fingers. So it starts from the collarbone. Oh, there we go.
So this is in Professor John Boyage's book, Breast Cancer Taking Control, and this is, I think, one of the better diagrams. And you can see the lymph vessels and the lymph nodes traveling through. So I thought I'd show that because, that will, let's segue into why we need to loosen and treat the pec minor.
For 2 reasons, Kate,
Yes.
2 reasons. That's a great photo, because when people know that they have had a lymph node dissection, you saw all the lymph nodes around that pec minor, they actually see that the scar is out here. And so they think that, it was somewhere out here. But in fact, they've put the surgical line there, they've put the scar there so that it won't be seen by many people. But what they do is that they then travel to pec minor and around pec minor. And so it's under, it's to the side, it's below. So it's kind of like all the nodes are snuggled around pec minor. And then they dissect out as many as that they need to. And what I think happens is that we end up with probably 2 mechanisms. One is that there has to be some, 3. Oh, I had 3. There has to be some scar tissue that forms because of the surgery. The other one is that during the surgery, I've seen photos where they actually get a metal clamp, and underneath the pec minor, they use the metal clamp to pull it away. And so I reckon if I was a pec minor, I would be going, ah! And so I think that it kind of goes into tight as a response. And then the third thing is that if the nodes have been removed, then the radiotherapy in that area is going to be as deep as that area. And so the radiotherapy changes to pec minor are going to happen.
Yep.
And so then what will happen is how people know is that they find it hard to go to ear, and then in fact they find it really hard to go back behind that. So if people feel that they can't go backwards from their ear, then that's an indication that pec minor is tight.
And often in those times that it's not just the reach out the back movement alone is going to help that. So then having a practitioner do hands-on work to help soften the tissue and get deeper to those muscles as well.
Yep. So stretch in this case, because there's so many features to this. It's not just because the muscle have just got, like frightened and got tight. There's scar tissue, there's radiotherapy. So there's other reasons. And so stretching won't undo that. And so the hands-on methods, and we've got a couple now that talk specifically to the pec minor and say, come on, you can release a little bit, you can get a little bit softer. They're the things that you want.
So in my practice and the way I do the hands-on is I use low-level laser therapy for the younger, and we talked about this in your workshop, the younger scar tissue, meaning the time frame between treatment and rehabilitation. And then cupping techniques. I use modern cupping techniques, which is very gentle techniques, and you did a bit of that too in your education workshop with us last year, just to lift the fibres away rather than pushing them onto each other to try and get that movement. Yep.
Yeah, there's laser lifting, and then a simple one is then self pressing, and each of those can be done by the therapist. And because of the radiotherapy component, if you can think that then just means there's a lifetime of input from radiotherapy to that area, then I'd be talking to the therapist about saying, well, what can I do at home? Because it might not be that, you certainly won't have to do it every day, but like maybe every 3 months, I'm just guessing, but so many times a year that we need to then keep talking to that pec minor and say, come on, you can be soft again.
Yes. And the other reason too, I know there was a couple of reasons why, we need to loosen that pec minor, is to get that lymphatic flow through that area.
Yes. So there's not only is reach important, but if we can break up the scar tissue and the thickness in the area where the lymphatics come from the arm, they've done that testing now, visualization, where you can see that the lymphatics still want to go there. The
ICG testing, and we talked about that. I had Professor John Boyages on the desk with me a few months ago, and we talked about the latest research and what they have found using ICG mapping, indocyanine green mapping, and to see that there is still lymphatic flow through that area, even with an axillary node dissection.
Yeah. Okay, we'll go back to, we're just talking about the reasons why and then the treatment. And the amazing thing, the amazing thing is if you do reach out the back test before and then after the treatment, then straight away you can see that there's been changes. So it is, it's quite easy to get changes, and that overall you would just be hoping and praying that that would make changes to the lymphatic flow. Now, I say hope and pray. I've seen my patients that it does change lymphatic flow, but it takes about 3 months for it to make a consistent change in lymphatic flow. And that, but even in the one treatment, that you can then feel the lymphatics in the arm and feel the tension in the arm. And after you do that one little bit of work and get increased range of motion in the testing, that straight away the arm feels softer.
Absolutely.
Amazing.
Yep. It never fails to surprise me. I love what I do because you can see the changes, and it's absolutely amazing. So what are your further developments then from with the reach out the back stretch or testing?
Yeah, just in time before COVID, I had developed reach out the back test for people while they were seated, and it was because we were doing a training in Darwin, and I wanted to show the therapists that we can actually use this test remotely. And so I had the lady, she was like 8 hours away from Darwin, and so we just got her to go through the test in seated, and so that we realized then that this can be a seated test. It allows therapists to see online, so that was a nice development. And then just because I'm talking to you, Kate, then I it creates this lovely explosion of energy, and it made me think. I love doing reach out the back test. I love using reach out the back as a stretch every morning, every night, and so I was so disappointed when my patients seem like they don't do it and they don't love it. And then it made me think, why is that? And I just went back to yoga, and I go, well, I do yoga when I'm told, but I don't do yoga when I'm not told. So why, and why? It doesn't make any sense, but it just is. So the very latest is that I've put it into the instructions into words, and by tomorrow, I was hoping for today, but by tomorrow I will have it in an audio so that people can hear me guide them through the reach out the back test, and so they can be in bed with their device before they get out of bed. Press the button that says, hear Denise talk about this.
Perfect.
And so I just think it's the yoga influence. It's my yoga experience, and so we've got a seated thing, and then I take people through.
Well, I'll have to put that up on the Bounce Back from Breast Cancer member login area, so our members can purchase, have access to that. So we will, once you have those details, Denise, I'll put those up so
nice.
People can click the link and listen to your beautiful voice talking them through the reach out the back.
Now, Kate, they, until they get sick of me, and that's, I'm just the prompt. I just want to be the prompt. I want to get people over the line, and I can assure you, you won't have to be listening to me forever, because you will get to love this stretch just as much as I do. I don't need anybody to tell me to do it, because I just know and love the changes that you get from doing it. I did think it only took 5 minutes, but in fact, it takes probably about 10 minutes if we do it slowly, and that's probably the last thing that I would like to add in on what I've done with that test, is that I will have the meditation version, and so I've combined the lovely breath of three through 5 in, or actually it should be 5 in, 8 hold, and then out for 13. But that's a really long breath. And so it's going to be 3 in, hold for 5, and out for 8. And when we do combine the movement with the breathing, it's just actually a beautiful body meditation.
Absolutely. Well, I can tell you that my patients love the stretch.
Fabulous.
That's the feedback.
I'll take it.
Excellent.
I dug deep for those, and because of my patients' help. So, you know, like it's one of those things that is quite life-changing and altogether too simple.
So you were scheduled to go over to the States to teach your workshop. Did that happen, or COVID happened first and then the online teaching?
Yeah, you're going to hear this first, Kate. You're going to hear this first, is that it's not this bit, but the consequences. So it meant that I couldn't go overseas, and how do we even think that we're going to be doing that in the near future? And so I had it in my mind that this information has to be taught face to face. And then so I had to overcome my thinking on that. And so then I turned it around, and then only about 10 days ago, I'm thinking, I just don't think I can get this hands-on, like you were talking about in the beginning. How am I going to do that? And at the training course, we have had the standard touch device, which is a pressure machine developed by Sarah Kamala from America. And Sarah heard my ESP messages, and we're working together now on being able to do the online training with the information, and they get the pressure device to use that while we're going through the training. So this is a brand new world, and Sarah and myself are joining together to bring good training to therapists.
Oh, that is fantastic news. Well, I feel very fortunate that I got the opportunity to do the hands-on training. But the fact that you're working around that and putting those two together is fantastic news for practitioners anywhere who can do it.
Anywhere, exactly. And that was the bonus, is that it means that there will be always one therapist in one town that absolutely needs to know this so that they can help their breast cancer survivors in their community.
Very, very good. So is there anything else that you have been working on recently? I know you're just like me and your brain doesn't stop, and there's always something that you're working on. Is there anything?
Kate, you have sucked it all out of me with your great interview skills. No, that is the very last cutting edge thing that we're working on. So no, you've got it all.
Brilliant. Fantastic. Well, thank you so much, Denise, for joining me again. And I have no doubt that I will have you up for another episode when there's more developments, and maybe, leading on from this with the seated reach out the back test. But I know my Bounce Back from Breast Cancer members will be hearing your voice soon.
Thanks, Kate. Thanks for your support. Lovely talking with you.
Fantastic. Have a great day, and we'll talk soon.